Good morning and welcome from all around the world to Structural Heart Life Cases, broadcasting directly from the Cardiac Catheterization Laboratory at the Fuster Heart Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist and also a professor of medicine, and I will be your moderator today. Remember, we would love to hear from you, so please send us your questions directly on the website or on YouTube. And you can review all our previous cases in our website, www.ccclivecases.org. We have an excellent case today. Let me transfer you directly to Dr. Sharma and his team for the presentation of the case.
All right, Pedro, thank you. And of course, welcome our viewers of the structural heart, which is also increasing in numbers, and we thank all of them. And the crew basically is the same, Dr. Tang, Dr. Keeney, Dr. Khera, myself, and we are 2 fellows here. We actually have total 4, right? Structural interventional fellow, but continue to will be a 3 in the future. But they're very helpful in arranging the cases and so, and able to do all cases by that. Many of them aortic TAVR cases, but of course, a lot more to learn in the mitral and tricuspid space. With that note, we, as you know, that 2 days later, initially was that should we do a live case or not? But we want to keep our pattern and don't change it. Habit. I will say that we are the creature of our habit. We want to keep it same way, and that's why we are doing it. But still want to make a point of the small aortic annuli, and that is what happening quite a bit nowadays. The patients who are coming, and that's the case we are going to show. And we have 8-9 cases for Thursday for structural. With that note, let me just present our slide presentation. These are our supporters, and the individual, the faculty. Okay, so all here, and we are cardiac anesthesiologist is Dr. Mui Trin, and will manage this patient. Conscious sedation or intubation? Intubation, yeah. So many times, in this stroke, not uncommon. While we use intubation maybe in only 20% of cases, but during these kind of live cases better, and that's the practice for many centers that just intubate so that you have all control of all the hemodynamic parameters and so. And then what we are going to show today is the TAVR in extreme risk patient using 26 millimeter Evolut for a small aortic annulus. So what does that mean? You see this is our episode number 76, 80-year-old. Female with a progressive shortness of breath, multiple risk factors and past medical history, as you can see, particularly the COPD. And I had just put this one for education of everyone, that what do we call mild, moderate, moderately severe, and very severe COPD based on the FEV1. So more than 70 is normal, less than 35 is very severe, and rest is in between. This patient has 62 predicted FEV1. And also on home, because of although EF is normal, but still because COPD oxygen dependent, that really increase the risk. As you remember, in the partner trial, original 1A, the patients who were on COPD, there was no difference in compared to not doing the TAVR, because those who are on COPD, because they have very limited lifespan of 6 to 9 months. Then patients obese with a BMI of 36, and many have few cancer surgeries, medications, AFib, and the EKG showing right bundle branch block, non-obstructive CAD, and echo showed severe valvular aortic stenosis with a high gradient. And we'll let our echo director here, Dr. Larakas, will tell us actually in person what is happening compared to this was the ECG and this was the echo. So if you can see,
yes,
Stem, if you can show us your live echo, go to the live echo, please.
Yes, good
now
morning.
You can turn the lights down.
Good morning, thank you, Dr. Sharma. So as you can see here, left parasternal long axis view, normal LVEF function, mitral aortic calcification. As you can see, the aortic valve leaflets are thick and calcified with restricted motion. RV appears good function. No much aortic regurgitation, maybe trivial, mild mitral regurgitation, mild to moderate tricuspid regurgitation, mild pulmonary hypertension by the measure of the pressure. As you can see, short axis view of the aortic valve, thick and calcified leaflets, restricted motion. Not much AI. You can see the turbulent flow because of the severe AS. 4-chamber view, apical view, normal LV function, maternal calcification, mild dilated RV because of her COPD, but mild decreased RV function, no pericardial effusion, no much maternal regurgitation. As you can see here, the maximum velocity we got from every angle is almost 3.4, maximum gradient 45, mean gradient 23, aortic valve area by both TAVR, by both VTI, and velocity is 0.78. So about 0.8 centimeters square, severe AS, and the stroke volume index is 30 ml per meter square. So it's low flow, low gradient aortic stenosis, and this is like what we call paradoxical low flow, low gradient because of normal ejection fraction. And this is the subcostal image, no pericardial effusion. Thank you very much.
Beautiful. All right, let's go back. So undoubtedly it is severe aortic stenosis despite the low flow, low gradient. And then we went through our usual, these all patients get the CT angio. So Sahil, you want to comment on it in terms of the annulus about this particular patient?
Oh, sure. So the annulus area is 351, but if you're choosing a self-expanding platform, you mostly look at the perimeter, which is 66.9, consistent with a SMART patient or a small annulus patient. The LVOT narrows down to a perimeter of 62.7, so very consistent with a patient who has a small annulus and a high BMI. Next slide, please.
So my question is, so we'll just do some theoretical discussion. The annulus dimension versus annulus area, which one is more important? So knowing that this particular case is 21, is still small, and the annulus area is 351. What if the annulus area was, dimension would have been 23 or 24, and annulus area was 350, 360? Does it matter?
Yeah, so that's a very good question. I mean, it depends on the ellipticity of the valve itself, right? So if the valve has a minor axis which is small and the major axis which is long, you'll get an average dimension which is higher. But for balloon expandable platforms, we tend to use area because as the concept is, it expands to the area. And for a self-expanding platform, you use the perimeter, which is, it conforms to the perimeter. So we all tend to rely more on area measurements for your balloon expandable platforms. But in those cases, we also look at the dimensions and calcification because we can undersize as well. But for self-expanding platforms, mostly perimeter is what we use.
Okay. So therefore, once you post-dilate the valve, whether it's a self-expanding, I mean, usually with the balloon expandable is the same size what you select. Sometimes you may add few cc's, but for the balloon, for self-expanding, then the annulus dimension comes in the equation. That is a 21.9 in this particular 21 point. So we'll post-dilate with only 21 balloon, non-compliant balloon, or you can go to 20 to 23.
It's again very good question. So if you are, so three parameters you should be looking at. So first is the IFU of your valve that you're using. So if the valve itself tells you you cannot use a balloon size bigger than this, you should not be using it. Number two is your average dimensions are fine for patients who are, as long as within the IFU, your average dimensions are fine if you don't have much calcification or hostile anatomy. But if you have hostile anatomy, you would actually use minimum or maybe a little bit more than the minimum. So it depends on IFU of the valve you're using. It depends on the amount of PVL, and number three is your calcification in the annulus or the LVOT.
So therefore, if you use a 26 millimeter valve, our Evolut Fx Plus, and we need to post-dilate, what will be our balloon size?
Yeah, so average is 21. I would use a 21 here.
Okay, very good. All right, so I think these are the very practical points I want to discuss with them. And the rest is all looks good. Anatomy point, coronary height point of view, and so on and so forth. So this basically is the patient. Although STS risk mortality is 4.7, but patient was evaluated by heart team and found to be at extreme risk in view of body habitus, multiple co-morbidities, and poor functional status. That's why patient is recommended for the 26 millimeter Evolut, and that you go through the design of it, and as you mentioned, all the points of the sinus of Valsalva, the perimeter, annular diameter fits into the 26 millimeter. Anu, anything we want to add? Okay. All right, so what we have now, so let's go through what you have done so far.
So we can maybe show the fluoroscopy, look at the two views. So typically we do the free cuts view.
that you can see here. So this one is very alveolo-cranial. You can see that quite horizontal actually in the aorta. You can see it's a small root based on the pigtail size, and when Sahil advanced to the cusp overlap view, so basically cusp overlap view, meaning that the right and the left cusps are overlapping each other. This is typically an areocaudal view. In this case, it's not that bad. Areo 13, caudal 7. So you can see that here, the reason why we do that, you see the non-cusp is sprayed open, so when you try to land the Evolut or any self-expanding valve, you try to aim not to be too deep on that side because that's where the membrane septum is underlying there, and that's how you can cause heart block. So that's why we start with this view at the initial deployment with the Evolut platform.
Okay. All right, so let's next level. Anu, what you need to do now? No AI, as we showed by the echo. And usually we go with the AR2 and with the straight Terumo of 0.38. Stiff shaft. I know a lot of people go with the AL, which we have said that AL sometimes gives a lot of trouble. So dilate aorta. So if it is like 4+, maybe go with the AL, but rest otherwise go with the AR2. And that actually we showed that in very early in the randomized trial in 91, 92, 93. See that? Right away, boom. Of course, hands are important also, but key is that using the straight tip Terumo and AR2 will get you in majority of the cases across the valve. So while we are getting this hemodynamics and so, Gilbert, maybe you can emphasize that if this patient would have gone for surgery, besides replacing the valve, knowing that it's a small annulus, what could they have done, or what is the current
So
trend?
that's a great point. So without any root enlargement, I would expect this patient would put in probably at 19. Okay. Which have severe PPM, as we know, right? Maybe even 21 at best. But you don't want to jam a bigger valve in because sometimes you can kink the coronaries or you can obstruct the coronary. So be very careful in surgery that you have a low coronary height. So that's very important. And so what we typically here would do is to enlarge the aortic annulus. Sometimes, obviously, in extreme cases, do a root replacement because that's the biggest root enlargement that you can do. But if you only do the root enlargement, make sure you also enlarge the sinotubular junction. There are people who, when they do the patch, they don't extend to the sinotubular junction. So now you have a big root, but you have a small STJ. So when you put a surgical valve in, you basically box the patient out for any TAVR option in the future. Why? Because the STJ limits the flow to the coronaries. So when that happens, you will not be able to do that unless you do leaflet multiplication, which of course is more complex than necessary. So my advice to the audience out there, if this patient should have surgery, because it's a hostile anatomy or other reasons, but small annulus, ask the surgeon to make sure the STJ, when they close the aorta, is big enough for future valve-in-valve option. It's very important now, irrespective of the patient's age, because we have seen patients who are 80-year-old, even for surgery, come back 10 years later, and still, you don't want obviously to have surgery at that time.
Why?
Yeah. So
can
clearly,
you put a hemo on the fluoro?
Hemodynamic screen on the fluoro,
Picture in picture, PIPE on the fluoro and make us full.
right there, right?
Great. Yeah.
Can you have us on the full screen? Operators on the full screen?
Yeah, we don't need echo right now. So
We don't need the echo.
So just to emphasize, now no longer doing the TAVR or no longer doing the surgical valve. We always have to think about the life of the basically lifetime management. So even when surgical valve is being implanted, always have to think about that can the TAVR be done in these cases 10, 12 years, 14 years down the road, and therefore used accordingly. And of course, enlarging the aortic root is a common, although they say it does increase few percentage of the mortality.
Yeah, I think you have to be careful. I think we now have some simplified techniques to enlarge the root. The Yang technique, I think some people are very, find it popular because you just, make a wide incision and then enlarge. But like I said, you have to enlarge the STJ. Whatever you do before you're coming out of the operating room. Otherwise, you haven't done the patient any favor. And remember, when you do the implanted surgical valve, don't cant the valve because that can affect the hemodynamics.
So some people try to jam a bigger valve and tilt the valve. They used to do that for mechanical valve, and that's a big problem because some of the leaflet's
How much
not
volume
opening
have you
and
given?
closing properly in diastole. So very important that you respect the native anatomy when you do these root enlargement procedures. So the other point we want to talk about, Dr. Sharma mentioned about area and dimensions calculation on CT, is that let's say you want to put a balloon expandable valve for whatever reason. This valve will be underexpanded when you do a CT. 21 millimeter is the average dimension. A 23 balloon expander will become a 21 only. So that will increase halt, what we've seen in the literature, and also potential early degeneration. So just beware of some of the limitations. You cannot stretch a balloon expander to a 23, no way. You'll just rupture the root. So just beware of this kind of differences in terms of when we do these procedures.
Okay.
Great. We have a first question from our audience.
Yeah.
The
Okay,
question
great.
is, so many valves available now. Which one has the best outcome as per data available?
Good question. Let's put it this way, there is no data available to favor one valve versus other. We actually had a review paper in JAMA Cardiology about 3-4 years ago, and now there are continuous, the data have shown, the both actually, the one which we know for sure, the short term in the small annuli, the self-expanding valve is the winner. Besides that, routine, multiple studies have shown with a choice trial and so up to 5-7 year follow-up,
150.
similar
150.
outcome. So nobody has been a winner yet, except the small annuli, self-expanding is the winner.
Inject.
And that is what we are using in this particular case.
Okay, 100, please.
No, 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 no,
High,
no, no.
high.
Came up.
Okay,
Go down.
150 now. Okay, yeah, inject, please.
Yeah, good.
Push the wire a
A
little
long
bit, please.
pacing run.
Yeah,
Okay, much
Good.
better.
okay, good. Inject, inject.
What is going
Hello?
on
Okay,
now?
good, good.
100,
100.
Too far down.
Sorry.
Yeah.
Actually, it may
No,
be
no,
okay.
no, it's fine, it's fine.
It may be
okay.
okay.
Floral, please, Dr. Skin. Good.
That's actually good.
It's good. It's good. It's actually free.
Yeah. Good.
After you deploy Sile or
please.
Gilbert will show to the audience the why you said
Leave the
good,
wire, leave the
because
wire.
some people might say that it was a
want to
little
leave the
lower.
wire now.
So just say it was
150.
deployed first, but then after that, yeah.
Also, while deploying, we have another question. What will be
Yeah.
the strategy if we have
120.
concomitant mitral valve disease?
The very good
Push the
point.
wire.
So actually, there quite
Push
a
the
bit
wire,
have
push
been
the wire,
shown that once you have concomitant mitral disease, you usually take care of the aortic first, and then after a few months, and we have many patients now come back for the mitral, and mitral is only the clip because other devices are in the process of getting approved. But tendine is very complex. It's still only
Come
in
out,
the MAC
come out.
cases. And the
One second.
M3 from Edward has a very good positive data. Might get approval early next year. We are part of the Apollo trial for the Intrepid, but it's a long way to go. It's still having a lot of enrollment issues in terms of a lot of exclusion. But to me, it will be that clearly we always do the aortic first, followed by the mitral. And let's see
Let's do,
where we are now.
Yeah.
We are going to do the
Is
aortogram.
the aortogram working now?
And surgery is an option too, right? Multi-valve disease.
Ready? Who's
Go.
Wow,
Very nice.
very good.
So
So let's post-dilate.
21
Any
millimeter
comments
balloon?
Yeah.
here, Dr. Kinney, for
Yeah.
the operator point of view?
Nothing.
not really. I think what you saw earlier, it rolled up, right? Because it's small LVOT, it can push the valve up. So you have to watch for that. And we usually do what we call a semi-rapid deployment technique. So you see, traditionally, the Evolut platform will say, go slow, start to flower slowly, you control pace, and then you make annular contact
Okay,
for
180.
80%.
I got it.
But what we do now, you can see earlier on, is that we actually
180.
let them post dilate first, and I'll comment more.
Yep.
What balloon we are using?
21.
21 true?
Yeah.
Okay, 21 true balloon is post dilating.
Back up.
Okay.
Let's do
hemodynamics. One time.
Okay.
So
Just,
anyway, so
quick
what
tale.
we was saying is that at the cusp of overlapping, when you start to flower, expose the capsule. That you can do it quickly. You don't need fluoroscopy. You don't. You don't need angiogram for that. You can save some contrast. Once the inflow start to flower, that's when you do a cine and do an injection to see how you are. And you can see today is that it was a little bit moved up a little bit higher because of the LVOT. Okay, and so we quickly recognize that and we recapture. So that was very important. So here you can see. We inject here, then we do a cine to see how it engages, and this you go quickly to 80% while you pace, so that you don't have any systolic motion to affect the position. So you saw we completely recapture because you don't want the partial recapture is high. You have to completely recapture. So then basically it descends. You saw it, and then we went back up quickly, so that again to minimize the motion of the heart that you're fighting against. And then you go to 80%, and you can see that here now, this is the LAO view. Now you can see this might be misleading. Say, oh, it looks deep, but it's not deep. You can see the base of the cusp. There's a calcium nodule at the base, right where the dot marker is, right by the pigtail. So you actually around 3 millimeters, which is we consider acceptable. And you can see with the Evolut platform, you can see the left cusp here with the delay stain. It's about 3 and 6 millimeters. And you can see the catheter is in the center, very nicely on this LAO projection. And so we believe that you can release. Now you can go a little bit higher if you like, but beware. When you have a small LVOT and you release, the valve may move up a little bit. Okay, so just be
very good point.
mindful of that. And so if you want to post-dilate, like what we did here, look at the post-dilatation. So they can see out here, this is the cusp overlap view. It's around 4 millimeters on the non. So that's very acceptable depth here. And then now look at how you post-dilate. Look at how much expands there. So you see that it might foreshorten a little bit on inflow. So if you only 1 to 2 millimeter depth, be very careful when you post-dilate that it might move up further, okay? So you can see before and after how much it expands. And that's why you can see here there's not much PVL, but we post-dilate because of the frame expansion. And you see how much on a 21 true average diameter, how much it actually expands on the average, on the actual frame itself. So this is clearly, before you expand, it's not 21 millimeter.
Right? So this will be more now.
Yeah, now you can see. We can go back to that same view
Yep.
for the audience.
Yeah.
So
this one.
Yeah.
So this is the one.
Yeah.
When we dilate,
Oh, yeah.
look at this.
Yeah. Look at this now.
Definitely, yeah. This is probably 22.5
Yeah.
or so. Now,
Yeah.
let me ask you another point about, now we talk about commissioner alignment, and particularly with the FX Plus.
Yes.
Going into the future in terms of opening the,
Yes.
going into the RCA or left main. How are we making sure that we are in that direction?
Yeah, so this is a great point actually Dr. Sharma brought up. So look at the diamonds here. Again, we can actually see that.
No, but how did you advance your catheter to get those diamonds in the right place? They're the large diamonds.
Then I have to ask Dr. Kinney. She's the one who did the app.
Yeah. Yeah.
Okay, so but you can see the big cells here. Look at the big cells here. So you can see the cells. That's how, the big window.
I think SS is asking about the technique
No,
itself
the technique
of the
of
valve, the commissure alignment.
So so to get there, you basically flush for 3 o'clock, sometimes 1 o'clock. But the head marker you see here, actually show this, Dr. Sharma. Yeah. This is the cusp overlap view. If you play this, you can see the head marker is
Center
facing
forward.
you directly, center front, and you can see one of the dots is actually goes towards the right side of the screens. Then you know that you have reasonable. Look at this, we call it the 2-1 ratio. 2 on the left, 1 on the right, meaning one of the dots where the commissure is on this view. It's reasonably well aligned. It's not perfect, but it's there. So.
And this is for tricuspid anatomy.
Tricuspid, yes,
so
that's
this
right.
Is for understand this concept is for tricuspid anatomies where you have 3 commissures.
That's right. With type 1 bicuspid is okay too, but not type 0, obviously. So.
Okay.
Okay.
Very good. Switching gears, we have another question.
Yes.
What is the update for TAVR in aortic insufficiency? Comments about motorized delivery system.
Yeah. So
aortic insufficiency is a problem. We've been doing mostly commercial cases in off-label manner because there's no FDA-approved devices. In terms of the NYHA valve has shown some very promising data. It's still being undergoing FDA approval. The trial has been completed. There's also another alternative J valve. It's also a similar platform. It's bought by Edwards. They're going to start the trial soon. That was on hold. And so those are really the 2 dedicated devices. However, we've been been using, certain balloon expandable and self-expanding valve, depending on particular anatomy. Reasonable results, actually. So for balloon expandable valve, we like to do that because the radial strength, but don't oversize too much. If you oversize too much, you might risk aortic root injury. Self-expanding valve, you have to watch the LVOT. If typically these patients have dilated LV, big outflow tract. So if you use a self-expanding valve, you run the risk of ventricular movement on release. So just be careful that it's not as predictable, and there's been literature on that. Prepare that if you use a self-expanding valve, you might need a balloon expanding valve to rescue if the self-expanding valve goes deep on release.
So, Dr. Tang, if you have to predict, when will we have the FDA approval for AI?
I would say probably mid to 2026. Yeah,
mid
the
next year.
earliest. Yeah, there's some regulatory hurdles right now they're going through.
And
That's
the company
wonderful.
point of view, they felt that it was infringement of monopoly. So commission, FDC, they said, hold on. So this is an issue going on. But, there's another novel technique which people have, some case reports have been, that what you do is, through the electrocautery, go through the leaflet of the aortic valve in the patient with aortic regurgitation. And once you have that, deploy your valve, now it's not going to move anywhere.
So the technique is basically interesting. It's like a unicorn, they call it. So basically, you do it intra-leaflet disruption and deployment, and only used for balloon expandable valve, because that is the most practical. And of course, again, you have to size appropriately still. But yes, that has been described as well. Just beware, remember, some of these aortic regurgitation is due to prolapse. If the leaflet is prolapsing, you cannot use that leaflet to actually go through and do the deployment that way. So just beware. And we always do these cases under general anesthesia and TE, because when you pace an AR patient, guess what? The blood pressure actually gets better because you unload the ventricle. So it's actually more important to do it under a very controlled hemodynamic situation in pure AR patients, because it's less predictable in the movement of the device.
Any comments regarding CE mark, or what about in India? Can we do it earlier?
Great question.
Dr.
I will talk about CE mark, and Dr. Sharma talk about India.
Talk about my valve.
And then, so CE mark in the Europe, actually the JenaValve is approved for pure AR. That's the only platform, and Dr. Sharma can comment on
it's
India.
not available in India yet. But actually, India, the number of valve is the my valve, which is more than 50%. Now, actually, in India also, they are doing about 500 TAVR per month. And one of the big region is almost 300 of them are with the my valve, very cost effective. Of course, all other valves are available. Medtronic used to be number 2 quite a bit and still remain number 2. But the big part has been the my valve. And somehow the Edward, while have a 74% of the market share globally, in India is a very small number. So my valve, then the Evolut, and then comes down to the Sapien. They're quite a bit using still as a Navitor. I think the Navitor and Edward are at a similar number, about 5-8% each. About 20-25% is the Evolut, and 50-55% is the my valve. So again, for aortic regurgitation, my valve is not for aortic regurgitation, although it has different sizes, maybe a little better, but it still remain. The selected cases of AI, aortic regurgitation, we have used current self-expanding or balloon expandable valve.
Yeah, I also want to make a point about mixed ASAR, which is a very actually non-infrequent entity. In those cases, you can treat it like a TAVR because you have some calcium to anchor. You just need to make sure, number one, sufficiently oversized, you don't end up migration. And two, when you pace, remember, it will unload the ventricle, reduce the AR, so you have to be a little careful on how you deploy the valve. But otherwise, you still do the same workup. We still do the oversizing the same, maybe a little bit more. Don't undersize. If you use a balloon expandable valve, make sure you oversize by around 10% at least, but don't go crazy like 20% because you can still rupture the root.
Okay,
one
another
more
question.
Thing about AI, if I can finish, is the sizing, right? They're out of size. So the reason I said my valve is it comes in a bigger size than your conventional balloon expandable platforms. That's being used for AI cases in India, the bigger my valve.
Yes,
another question from the audience, changing gears on general concepts. What is our percentage of patients after TAVR that requires a permanent pacemaker here at Mount Sinai?
About 10%.
Excellent.
about 10%. The new permanent pacemaker, 10%, which a little higher, I would say the number 1, 2, 3, maybe about 12% with the Navitor, 9% with the Evolut, and about 5, 6% with the Sapien. We actually surprised. Even with Sapien, we have higher number. I don't know why.
So, remember, right bundle branch lock is the single most important predictor of any pacemaker in TAVR. So if you exclude the right bundle branch block patients, then the real pacemaker rate really is the most accurate number, because remember, 50-50 with someone with a right bundle branch block. And most of the self-expanding valve, unless you implant very high, and also we look at the membrane septum routinely on our CT scan, so that will tell you also your predictive value of your pacemaker need. But it's just something that you need to discuss with the patient. That based on your platform, your anatomy, and your depth of implant, the pacemaker rate would vary. So.
Yeah, keep on saying, go onto the fluoro, show it what you're doing, so that everyone, how we are closing the arteries here.
Yeah, so go live first. Yeah, so this patient has a very high BMI, and these are the kind of patients I do an up and over and do a dry closure, that is a balloon tamponade. The reason is when they start ambulating, and if any of the suture pops, it becomes it becomes a big issue. So any patient who has a high BMI or you cannot reverse anticoagulation, we just tend to use more up and over and balloon tamponade in the end. Although the closure was perfect when the sheath came out, I'm just going to do 3 more minutes just to make sure there's no issue going forward whatsoever.
Yeah, to Sahil's point, some of these patients, if they ambulate early, for example, you want them to, get up and round, all they take is a cough, a little bit pressure, and then, things can open up. So you certainly don't want that in a morbidly obese patient.
So this is a routine technique. How many cases we do up and over wiring only?
Yeah, so a very good point. So we have a training program, and I think fellows need to be really well trained in endovascular as well. So almost I tell them, I push them to do up and over wiring, at least in all cases, leave a wire in there. And in 10 to 15% of cases, we'll actually do a balloon tamponade at the end of the case.
So almost every case is getting
Almost
the
every
wires.
case. Yes.
Okay. Any situation you'll not use the wiring?
Yeah, so anytime there's an EVAR case where you have 2 limbs or patient has a very acute angulation, then you don't waste time doing up and over wiring. Although you can in those cases, but we try not to because the equipment becomes really expensive. And otherwise, for the most part, or they have had a renal transplant on one side, then we don't take access, a single access case. But outside of those, I really promote them to do up and over and get really good at it.
Okay. All right. So with that note, any other question? Otherwise, we can continue our presentation.
We're good with questions. I will
Okay.
interrupt if we have a new one. Yeah, go ahead, Dr. Sharma.
Yeah. All right. Let's go to our presentation. So what I would try to give the latest always now about the few TAVR publications, SMART trial, 2-year outcome, then the OPRA TAVI trial, Dedicate trial, and the recent European guidelines. So clearly, the SMART trial, which was presented 2 years ago, now we have 2-year follow-up. Soon we'll have a 3-year follow-up. The comparison was in a small aortic annuli, less than 430 millimeter square, Evolut Pro or FX compared to Sapien 3 Ultra, and it basically showed that the earlier data were, before randomization, that Evolut will give you a better platform hemodynamically, and that actually happened. This is now we have the 2-year follow-up of these patients. This was the 1-year follow-up. On the right side, bioprosthetic valve dysfunction, because the structural and non-structural deterioration and the balloon expandable compared to self-expanding, there was big difference, 41 versus 9.4%, although outcome of the mortality, stroke or heart failure rehospitalization, these are the primary endpoint, was about 10% in both the groups. So this now, 2-year, same, 17.6%, exactly identical outcome. The major endpoint of the mortality, stroke or rehospitalization, while the one bioprosthetic valve dysfunction still continues to be very good in the Evolut group compared to the Sapien group. So Gilbert, what is the reason that we have such a dramatic difference in the hemodynamics, but our outcomes still have not changed in this smart trial.
I mean, both are excellent platform, right? I mean, as you alluded earlier, Edwards, is the market leader right now for balloon expandable platform. I think it's the definition that you see here. It is the SAPIEN 3, not the Resilia. So the smaller annuli in terms of the valve opening, they redesigned it. So we've seen that in real life too, that the gradients are on average statistically higher than Evolut, which always been with the soprano design having single digit gradient like you see here.
Yeah. So this part will continue, and so basically at 2 years also, we got a very good from the hemodynamic point of view, although the MACE, you can say, was identical between two as shown here. So this is a plus. Then there is another registry was from North America and Europe, and the comparative analysis of the Evolut Pro versus SAPIEN 3 Ultra called OPERA-TAVI registry, same in the small aortic annuli, and basically showed about 250 plus cases with a match between two similar data what we saw actually in the except that maybe a little different here in terms of slightly lower hospitalization in the Evolut group, but overall no difference in the trial endpoint, except the hemodynamics were better. Now, you see the death, stroke, heart failure, hospitalization, they were at 1 year, similar, short term maybe slightly different, but overall it shows that the both platforms do very well, but clearly the hemodynamics point of view, SAPIEN is inferior to Evolut in the small aortic annuli, and that is defined as less than 420 millimeters. So this is basically showing that valve performance. Then there was another trial called Dedicate. The all-comers, always we have a lot of enrollment, inclusion, exclusion criteria. This trial done from Germany in low to intermediate risk AS, patient compared TAVI versus surgery, and all-comer basically, and they have 1 year data of the follow-up, and actually showed to the first time that at 1 year, the TAVI was superior to surgery. This is a very interesting, and now because there was a lot of consistency when your TAVI was done, for the surgery there were a lot of heterogeneity. The 2/3 were the balloon expandable, about 32% were self-expanding, and there was some mix about few percentage. But overall showed in every endpoint, as you can see here, death, stroke, new, of course pacemaker was higher in the TAVI group, but most of the points were superior in 1 year in the TAVI group compared to surgery. So, Gilbert, what do you think the reason is such a big difference at 1 year?
I mean, surgery, you always take an upfront hit, right, in terms of bleeding, acute renal injury. So, I think the 1 year mortality, 6.2%, seems a little bit high. Yeah. I think, for surgical AVR, isolated surgical AVR, these are not combined procedures. So, and also stroke. But, data is the data. So, yeah.
Yeah, but just to say that there you will find a lot of, and we also know with the Notion 2 trial that surgery almost won over the TAVR.
Yeah.
Because of particularly low risk young patient, particularly many of them being bicuspid, surgery did better. Now, then the recent guidelines. So we recently got the guideline from the structural heart disease, and remember this was the earlier, before the current guideline, 3 years ago. Surgery versus TAVR in Europe, 75 years. And then in America, less than 65 surgery, more than 80 TAVR, in between with the heart decision making. So what has happened now, that new is now that 75 has gone down to 70. So very important. 75 has gone down to 70, and the rest is just about a little revised recommendation. So clearly the horizon of the aortic valve has increased, and same way also that anytime you're thinking the lifetime management of the patient based on their life expectancy. And we all know what favors SAVR, what favors TAVI, and many of the ROS procedures, which actually Sinai is a leader in that, and continues to do, particularly in young patient, doing the ROS. And more important, as I mentioned, it's no longer that you just do the TAVR, that you are optimizing your results in terms of expansion, depth, orientation, and coaxiality. So that is all comes into equation, whether it's a balloon expandable or self-expanding. So idea there is that you have a small valve More hemodynamic, they have higher valve degeneration. So the second is the double tap, which we published also, and came data from Canada also. The double tap is probably useful to expand the valve further and has shown in a non-randomized fashion better effective aortic orifice. So clearly optimization, and the same thing with the dedicated randomized clinical trial showed that TAVR was better because there was high reproducibility of the TAVR procedures and so. So key is just to say that we need to optimize surgical transcatheter valve with proven long-term durability, consider surgery with patient with aortic root enlargement, which we talked, implantation of supraannular transcatheter valve in patient at risk of patient prosthetic mismatch. So that's what we do, and this is kind of case with a small aortic annuli. Then no implantation of stentless prosthesis or prosthesis with externally mounted leaflet in patient risk for coronary obstruction. Very important. So because future TAV and SAVR cannot be done, and then anticipation of the feasibility and risk of a possible future intervention always need to be considered, whether you are doing a TAVR or the surgery. Device choice, height, and so on and so forth, we always take into equation. Now, what also has happened, and they have kind of touched it, that we always waited for the symptoms. But we also know that before your symptoms comes, which is therapeutic goal used to be in the past, that of course the death, hospitalization, increased quality of life when you do the TAVR. But what happened when subclinical issue? And that is the asymptomatic patients, because there is irreversible cardiac damage is happening. Many times you replace the valve, but the outcome does not change. Procedural risks are there. So people have been considered having a trouble that what you do for asymptomatic. And as you remember, each have a pro and con. And more importantly, that clearly the delaying the intervention can give rise to a permanent damage. So you may replace the valve but don't show the benefit, and myocardial damage continues to occur in these patients once they develop aortic stenosis, symptoms or not, and they all have correlated with subsequent bad outcome. Now, so what has happened? That basically what we knew exactly, the class 1, the intervention recommended for asymptomatic patient with severe AS, EF less than 50%. And there, the low EF is not from CAD or others. So that has been the recommendation. And then patients with a severe AS and EF more than 50, but if they have very high gradient or they have a severe valve calcification, rapid progression, high BNP, and clearly have been a type class 2A indication. But now what has happened? In last 4 or 5 years, the two groups of patients, one surgical, one TAVR. We have two randomized trial of the for asymptomatic severe AS in the TAVR group, early TAVR and Evolve. Both showed that early intervention is better. Evolve required the myocardial necrosis, and then in the surgery, two trial, Avatar and Recovery, both showed that intervention or surgical valve replacement, and the earlier the TAVR valve replacement is better than waitful watching. So waitful watch is no longer recommended, but only thing is, they have not changed this guideline. So now we have 4 trials, 2 interventional, 2 structural, maybe it was just too early for the guideline, they still kept it as a 2A. So this remain, to me, I think this should be very rapidly 1A. There's no question, because you have 4 trials, all consistently showing asymptomatic severe AS should get a class 1 indication. Bicuspid remains a trouble. We know that in Notion 2 trial, bicuspid are higher stroke, annual rupture, paravalvular leak, many factors, and so they still remain 2B. That appropriate case which undergoes TAVR, those who are troublesome for the surgical risk. So surgical anatomy is high, and coronary anatomy, valve anatomy is okay, then only they go for bicuspid AS, TAVR, and it's a 2B. But now, as you know, a dedicated randomized trial led by Raj Makkar is being planned for anatomically suitable bicuspid AS is being planned, and we will be getting the data and will participate in this bicuspid aortic stenosis trial. So let's complete our presentation. The 2-year outcome of the randomized trial of the self-expanding versus balloon expandable showed the self-expanding superior hemodynamically, but clinical endpoints were not different. The registry comparing Evolut versus Sapien again showed favorable outcome with the self-expanding. And then dedicate trial comparing TAVR versus SAVR in low to intermediate risk patient, better outcome with TAVR versus surgery. And lastly, new updated European Society guideline has shown some expansion of the TAVR indication, except they still did not make a class 1 for the asymptomatic severe AS. So 3 questions. One is the following are the 2-year outcomes of the SMART trial, comparing Evolut versus Sapien in a small annuli, except similar effective aortic orifice, composite clinical outcomes are similar, lower bioprosthetic valve degeneration in Evolut, and similar mild AR between 2 groups. The clearly effective orifice was better with the self-expanding 1.9 versus 1.5. So A is wrong. Second, following statement is not true about the results of the dedicate trial comparing TAVR versus surgery in all-comer low to intermediate risk AS, where primary endpoint of death or stroke was lower in the TAVR versus surgery, similar death rates between TAVR versus surgery, higher new permanent pacemaker in TAVR versus surgery, and similar cardiovascular rehospitalization. The difference was there was a lower mortality in the TAVR group compared to surgery, so that's a wrong answer. And then lastly, the 2025 European guideline favored the following, except TAVR is recommended in patients more than 70 compared to 75 before. Then mode of intervention TAVR or SAVR should be based on the heart team discussion with all the available data. And asymptomatic severe AS is now class 1 indication for TAVR, and patient with myocardial fibrosis receives higher aortic valve intervention. So clearly the C is wrong, but it's not a class 1 indication for TAVR yet. So with that note, I complete my presentation.
Excellent, Dr. Sharma. Thank you so much. I have a very important announcement. The day after tomorrow, that's Thursday, December 11, we have our New York Transcatheter Valve Symposium. It's going to be about 10 hours of teaching, direct cases, and multiple discussions. So go ahead and register. You just go www.newyorktranscathetervalves.org. We still have time.
There, yeah.
Yeah,
So
it's
right
over there. Yeah, go ahead.
And we'll do 8 to 9 cases, and it's right here at Mount Sinai in the Stern Auditorium. And Gilbert has invited excellent faculty. Will be the lot of discussion about transcatheter and surgical. There are few surgeons are there and provide the flavor. Every time we started with the TAVR, this time we are starting with the mitral and tricuspid, because that's where the TAVR has become routine. People say we are bored with the TAVR, you need to show something different. So we actually not only going to show cases like a small aortic annulus, more importantly some valve and valve, and the leaflet obstruction coronary obstruction using the shortcut device, which was approved few months ago. And we'll be using that in one particular patient, maybe more, but just to prevent obstruction, which is the big, forward leap compared to what Basilica used to take so much, time. Now you'll see how quickly, within few minutes, you can cut the leaflet and implant the valve. So a lot of new things will be shown during our transcatheter valve symposium, and we invite everyone to come here, and we'll try to make it also after they start some cases on the online online access also.
Fantastic. So 2 more announcements. First, you can go ahead and review at www.ccclifecases.org all our previous cases, as well as today, this afternoon. And most importantly, we have this structural heart life cases every second Tuesday of the month. So the next one will be Tuesday, January 13 at 9 a.m. Thank you so much.